Hey there, fellow grad students. I have 17 practice questions for you on the psychiatric aspects of chronic pain. Ready? Let's learn psych fast. Question 1. Which neurotransmitter is commonly associated with the descending pain modulation system in the brain, influencing psychiatric component of pain management? Is it A, serotonin, B, dopamine, C, GABA, or D, acetylcholine? The answer is A, serotonin. So think of serotonin as the brain's pain modulator. It's closely linked to the system that helps manage both physical pain and the psychological aspect of pain. Now, dopamine, it is a big deal for pleasure reward, but when it comes to the pain system, it's not as directly in the spotlight like serotonin is. Then there's GABA. That's the chill out neurotransmitter. Like dopamine, it's not the main player in the pain modulation system. And lastly, acetylcholine. It's got a bunch of jobs like helping muscles communicate, but in the world of pain modulation, it's not taken center stage. It's like the supporting actor with a diverse skill set. Question 2. Which brain region plays a crucial role in emotional, motivational aspects of pain and often targeted in psychiatric interventions for pain management? Is it A, the hippocampus, B, amygdala, C, thalamus, or D, hypothalamus? The answer is B, amygdala. So the amygdala is like the emotional center of the brain, especially when it comes to pain. Psychiatric interventions often focus on it because it's a key player in the emotional and motivational side of dealing with pain. Now, the hippocampus is more about memory and learning. It's got a job, but it's not directly hooked up to the emotional and motivational parts of the brain like the amygdala is. Then there's the thalamus. It's all about relaying sensory information, but when it comes to the emotional side of pain, it's not taking the lead role. And the hypothalamus, it's a multitasker involved in various functions, but when we're talking about dealing with pain through psychiatric interventions, it's not stealing the spotlight. It's more like a background player. Question 3. In the context of psychiatric interventions for pain management, what is the role of biofeedback? Is it A, enhancing pain medication efficacy, B, teaching patients to control physiological responses, C, inducing analgesia through meditation, or D, addressing psychiatric side effects of pain medications? The answer is B, teaching patients to control physiological responses. So biofeedback is like this cool technique where we help patients take control. We teach them to manage things like muscle tensions, all to make dealing with pain a little bit easier. It's like giving them the reins to their own body. Now, meditation is awesome too, and it can totally be part of the plan managing pain, but biofeedback is like the coach specifically training you to be the boss of your own body's reaction. It's all about giving you skills to take charge of how your body responds to pain. Question 4. Which patient assessment would indicate that salicylic toxicity is occurring? A, GI bleed, B, increased bleeding time, C, tinnitus, or D, occasional nausea? The answer is C, tinnitus. If you've got a bit too much salicylates going on, you might notice some things like your ears are ringing or you're having a bit of trouble hearing. Maybe your vision isn't as clear and you're sweating a bit more than usual. Oh, and you might feel like a bit out of it, kind of like dizzy and confused. Plus, there's a chance you'll feel like taking a nap, having a touch of a fever, and maybe even a bit of nausea with a side of vomiting. But hey, don't worry about the GI bleed. That's more like a long-term thing. I know we talk a lot about it, but that's long-term and not a sign that you've had too much at once. And if you're treating clots, it might mess with bleeding time, but that's just part of the process. So if you're feeling a bit queasy after salicylic treatment, it's not you, it's just a common side effect, not a sign that you've overdone it. Question 5. The phenomenon where exposure to chronic pain leads to changes in the CNS amplifying pain perception is known as what? A. Pain catastrophizing. B. Central sensitization. C. Nociceptive desensitization. Or D. Psychosomatic amplification. The answer is B. Central sensitization. So what is this? It's like your CNS is turning up the volume on pain, a bit too loud for comfort. And guess what? This happens a lot with chronic pain. It's like your nervous system is going into overdrive. Now, forget about nociceptive desensitization. That's not really a term that's thrown around much. And then pain catastrophizing. Well, that's like when your mind takes a detour into the worst case scenario land. It's a cognitive distortion and it's a bit different from the central sensitization gig. So we're talking about the wiring in your nervous system here. And the psychosomatic amplification, yeah, it can play a role in how you feel pain. But when we're talking about changes in the central nervous system, that central sensitization is doing its thing. Question 6. Which sign or symptom displayed by a patient would be indicative of opiate withdrawal? A. Bradycardia. B. Diarrhea. C. Lethargy. Or D. Hypothermia. The answer is B, diarrhea. Okay, so if your patient is going through opiate withdrawal, it's like the body's doing a bit of a dance. Think of it as a dance. They might feel muscle spasms, aches in the back, belly, legs, and basically a whole body workout they didn't sign up for. Oh, and there's cramps, hot and cold flashes, and insomnia throwing their own party. Add nausea and vomiting and serious sneezing sessions to the mix. And it's like a symphony of discomfort. Now, don't get this confused though. If one's heart rate is doing the speedster thing, that's actually a sign of opiate withdrawal, not the slow and steady bradycardia. The feeling lazy? Nah, it's more restlessness. And forget about getting too chilly. Fever is the name of the game during opiate withdrawal, not hypothermia. So the body's throwing a bit of a tantrum, but there are signs that tell you that your patient has opiate withdrawal talking. Question 7. What is the advantage of taking an NSAID that is a COX-2 inhibitor? A. Medication is cheaper than aspirin. B. There are fewer GI adverse effects. C. They are more effective than COX-1 inhibitors. Or D. They have no adverse effects. The answer is B. There are fewer GI adverse effects. All right, let's talk about these pain relievers. So the COX-2 inhibitor NSAID are like the superheroes of your stomach. Fewer belly issues compared to salicylics or COX-1 inhibitors. And hey, good old aspirin, it's like a budget-friendly buddy in the analgesics gang. Now, when it comes to anti-inflammatory magic of NSAID, it's all thanks to COX-2 inhibition. But here's the catch. Messing with COX, in general, brings along some not so fun side effects. Yep, all these meds have their quirks and yeah, they can cause some issues. So in the world of pain relief, they're like good guys, but they come with a bit of baggage. Just the usual stuff you've got to deal with when you're taking meds. Question 8. What term is used to define awareness of pain? A. Tolerance, B. Threshold, C. Perception, or D. Sensation? The answer is C. Perception. All right, so we've got some terms we need to unpack here. So pain perception is basically you being aware that not so fun feeling called pain, also called nociception. It's like your body's way of saying, hey, this hurts. Now, pain tolerance is your superpower. It's your ability to tough it out when things get ouchy. You know, like enduring pain like a champ. And then there's pain threshold. That's the moment when you go, yep, this is definitely painful. It's like the point where your body acknowledges that something's not quite right. So pain itself, It's this whole experience that brings together feelings, emotions, and even triggers responses in your body, like automatic system, your mind, and even your muscles getting in on the action. Pain's a whole package deal. Question 9. Which statement is true about neuropathic pain? A. This pain is the result of stimulus to pain receptors. B. Patient describes it as a dull and aching. C. It commonly originates in the abdominal region. Or D. The pain is a result of nerve injury. The answer is D. The pain is a result of nerve injury. So neuropathic pain is like the pain that happens when something goes haywire in your nervous system, like trigeminal neuralgia. It's like your nerves are throwing a bit of a party, but it's not a good one. Then there's nociceptive pain. That's your body reacting to a signal like touching a hot stove. Usually it's like a dull, achy feeling, not fun kind though. And lastly, visceral pain is the pain that sets up camp in like the abdomen or the thoracic cavity. It's like a not so great sensation that originates in those regions. Question 10. A 46-year-old man is seen by an occupational health doctor due to long-term sickness leave. He states chronic lower back pain prevents him from working, but examination findings are inconsistent and the doctor suspects non-organic causes symptoms. This is an example of A, conversion disorder, B, Munchausen syndrome, C, malingering, or D, somatization disorder. The answer is C, malingering. So lying or exaggerating for financial gain is malingering. For example, someone who fakes whiplash after a road traffic accident for an insurance payment. So I'm going to go ahead and just define those other terms as well, because you do need to know them. So what's somatization disorder? That's multiple physical symptoms present for at least 2 years, such as patient refuses to accept reassurance or negative test results. Hypochondrial disorder, that's the persistent belief in the presence of an underlying serious disease, like cancer, i.e. like a patient that refuses to accept reassurance or negative results. Conversion disorder typically involves a loss of motor sensory function, so the patient doesn't consciously feel the symptoms, so it's like a fictitious disorder, or seeking material gain like malingering person would. Dissociative disorder is disassociation is a process of separating off, certain memories from normal consciousness. A dissociative identity disorder is the new term for multiple personality disorders, as is the most severe form of dissociative disorder. And in fictitious disorder, that's also called Munchausen syndrome. That's the intentional production or physical or psychological symptoms. Then, of course, malingering. That fraudulent simulation or exaggeration of symptoms with intention of financial or other type of gain. Question 11, true or false? Pain behavior due to psychological pain can appear very much out of proportion and unbound to tissue pathology. True or false? The answer is true. So when someone's dealing with the psychological pain, their pain behaviors can seem way more intense than what's happening in their body. It's like their presentation is shouting, big problem here. But when you look closer, there might not actually be any damage or issue with the tissues. So in a nutshell, it's a bit like your emotions taking center stage and making the pain show look way more dramatic than what's really happening under the hood. Question 12. In psychiatric evaluation for pain management, which personality disorder is often associated with exaggerated pain complaints and difficulties in treatment adherence? Is it A, borderline, B, schizoid, C, obsessive compulsive personality disorder, or D, antisocial personality disorder? The answer is A, borderline personality disorder. All right, let's talk about personalities and pain. So if someone's dealing with borderline personality disorder, they might be the drama queens of pain complaints. It's like they're turning up the volume on how much it hurts and sometimes sticking to the pain treatment plan can be a bit of a challenge for them. Now, if we switch gears to schizoid personality disorder, it's a whole different vibe. I mean, these folks are more about flying solo, not so much into social stuff or get into emotionally warm. Pain complaints, that's not their main gig. And then there's antisocial personality disorder. These guys are known for not caring much about other people's rights, but when it comes to pain, they're not the one that's exaggerating. Lastly, if someone's dealing with OCD, their pain concerns might be more specific, but when it comes to cranking up the drama on the pain complaints, that's still more of the borderline personality person. Question 13. What term describes the phenomenon where chronic pain patients may experience worsening pain intensity due to heightened psychological distress? Is it A, hyperalgesia, B, catastrophizing, C, allodynia, or D, neuropathy? The answer is B, catastrophizing. All right, let's break down some more pain-related terms. So, catastrophizing. That's when your brain decides to play the worst case scenario game. In pain management, it's like your psychological distress is turning up the volume on how much your pain you're really feeling. It's like your mind is adding the extra drama to the pain story. Now, hyperalgesia is a different beast. It's when you become super sensitive to pain. But here's a twist. It's not about your psychological distress making the pain worse. It's more like your pain sensitivity is cranked up, separate from what's going on in your mind. Then there's allodynia. That's when something that shouldn't hurt suddenly does. It's like your pain signals are getting all a bit mixed up. And neuropathy, that's the nerve damage or dysfunction, not so much about your psychological distress making the pain worse. Question 14. Which psychiatric disorder is commonly associated with a higher prevalence of chronic pain conditions? Is it A, panic disorder, B, depression, C, generalized anxiety disorder, or D, bipolar disorder? The answer is B, major depressive disorder. So if you're dealing with major depressive disorder, there's this kind of like tag-along friend called chronic pain. It's like they're buddies and they go way back. It's these two-way street, like depression and pain, they like to hang out together. That's why SSRIs, those mood-busting meds, those are the ones that are often in the mix because they can also help ease the pain. So double duty, Now, anxiety disorder, that can chip in on the pain scene too, but when it comes to real MVP of chronic pain, major depressive disorder takes the crown. And here's a little trivia for you. Panic and bipolar disorder aren't really the regulars in chronic pain club. They're more like occasional visitors, not the ones consistently linked to it. So when it comes to mood and pain, it's a bit like a dynamic duo, with depression leading the way. Question 15. Which psychiatric medication is often used to manage neuropathic pain, especially in conditions such as diabetic neuropathy? A, TCAs, B, atypical antipsychotics, C, benzodiazepines, or D, MAO inhibitors? The answer is A, TCAs. All right. Let's now talk about dealing with nerve pain. TCAs, or tricyclic antidepressants, are like the superheroes here. They're often the go-to for managing neuropathic pain, especially the kind that tags along with conditions like diabetic neuropathy. These meds bring some serious pain relief vibes. Now, atypical antipsychotics, not really the frontline warriors for nerve pain. Benzos, nope, they're not taking the lead either. And those MAOA inhibitors, they're not the first ones to step up to the plate when it comes to handling neuropathic pain. So when it's nerve pain you're dealing with, TCAs are often the stars of the show, bringing some much-needed relief to the party. Question 16. You have a nonverbal adult patient. Which type of pain scale assessment tool is the most accurate to use? A, the TPPS, B, the FLACC, C, the POCIS, or D, MOPS? The answer is B, FLAC, F-L-A-C-C. All right. So we got some tools for checking in on pain, especially for those who can put it into words. So the FLAACC scale, it's like our superhero for nonverbal patients. We use it to assess how they're feeling. We look at their face, legs, activity, cry, consolability. Each part helps paint a picture of their pain. Now, don't get this confused though with the other scales like the toddler, preschooler, post-operative pain scale. That's what TPPPS is. The Pain Observation Scale for Young Children, the POCIS, and the Modified Objective Pain Scale, MOPS. They're not the go-to for nonverbal PALs. The FLAC scale is like our special tool just for them. So when they're not talking, we got scales, and the scale we're going to use is FLAC. That's the one we trust for our nonverbal buddies. Last question, question 17. Which opioid receptor subtype is associated with analgesia, respiratory depression, and dependence, making it a key target for opioid analgesics? Is it A, mu receptor, B, kappa, C, delta receptor, or D, sigma receptor? Answer, mu receptor. All right, so let's talk about these MVPs in the world of pain relief, the receptors. So the mu receptor, that's the go-to for opioid pain meds. It's like the star player associated with pain relief, a bit of euphoria, and sometimes the not so fun stuff like respiratory depression and dependence. It's the full package though. Kappa? Now kappa, that receptor also has a role in the pain game, but they're not the main targets for our opioid pals. Activating them might bring some pain relief, but here's a catch. It can come with a side effect of dysphoria, not the happiest vibe. Delta receptors, yeah, they're involved in pain managing, but they're not the first pick for opioid analgesics. Their specific role in easing pain is still a little bit of a mystery in the research world. And sigma receptors, they're not the usual suspects in opioid effects. They're like the outliers, investigated for their potential in various body functions, including neuroprotection. But when it comes to opioid pain relief, they're not stealing the spotlight. All right, thanks. Go ahead and just click on this video. Thanks.